I will give a very brief talk, but I'm going to put up some slides that I think all of us can relate to and enjoy. Basically, I do a lot of minimally invasive spine. If I see the spine and see a lot of blood, I get lost. I just need a tube and an incision about 1.5 inches to do my surgeries. So I had to put this disclosure slide in because they asked us to, and I haven't looked at it since I wrote it. So the important thing is, what is that wall? I don't get it. I don't understand. I don't know why it's there, but it's there. It's sort of like the shoes. You know, why do we have to change our shoes? Why do we get yelled at every time we come here? We have to put new shoes on. You go up in the ICU, change your shoes. But my feet, my toes smell. I mean, what are we protecting? But this wall, I just don't get. But it's there, and I've sat on it. I've looked at it for the past 3 times I've been here. And I always feel bad for the patients that we sort of get them halfway over, and then they kind of collapse down on the wall, and then we pull them up on that nice gurney to bring them to the OR. So, moving on, the power of minimally invasive spine surgery. Again, pictures, we saw this yesterday. I was being made fun of last year because I took off to Uganda. Victor had to check to make sure I wasn't kidnapped, but I can't stress enough, if you have the chance to see the silverback gorillas, you got to do it before we destroy the environment. There's a very small number of them, and they're just incredible to see. It's almost life-changing. So here's my first case to show what we can do. We had a 22-year-old female. She got shot. She was just minding her own business on the porch when a group of 13 and 14-year-old males began yelling at both her and a friend. One of the 13-year-olds pulled the gun out. Patient saw the gun, jumped in front of her pregnant friend, turned her back to the boys, and she had a gunshot wound to the back. She immediately, when I spoke with her before surgery, she noticed that she couldn't feel her groin area, she couldn't lift her foot, she had bilateral foot drops, and she did not regain all neurologic function during the initial presentation. These are her images during the trauma workup. Do we have any medical students left? Residents? They all ran away. They're all too busy eating. So, you know, for those of us who've seen the gunshot wounds, we can see that right behind the vertebral body of L5. You can see this amazing solitary projectile that lodged itself in the canal. I figured, since this would be an exciting case, why not just stick a Metrex tube down there, put it right over the area of the projectile, do a hemilaminectomy, and just pull it out. A lot of people talk about CSF leaks, fixing the nerve roots, all sorts of extravagant things, but when you put the tube down and you do your opening, do your dilation, it's all about how you manage the tissue. A lot of people have wound breakdowns for various reasons. I am not a big fan of using any cautery. I will make my incision, I will raise the soft tissue and musculature with the periosteal elevator right off the bone, and then I'll put my dilator down there. There are people who like to cauterize a lot, but as I tell my patients, well, should I put heat or should I do cold? I always tell people cold is better, because how do you preserve a piece of meat in your freezer? You freeze it. How do you cook it and destroy it? You cook it. So heat is not my friend in my view. So when we start thinking about doing a case like this, and the fact that you know you're going to have torn dura, you're not going to be able to fix it primarily. You're going to have a CSF leak. And I'm sticking this tiny tube in there. Tissue preservation's the key. So I put an 18 millimeter tube. I just used loops that had light, laminotomy, was able to pull the fragment out. You can obviously see me pointing at it because I thought that was cool. And you see the before and after. And I'm actually retrieving it just with a pair of pituitaries. I was able to actually show the images. You can see the Metrex retractor that's just off midline. So I like to dock right on top of the lamina. If you think of the lamina as a roof, and if you try to put the bottom of your retractor as parallel as you can and just dock right on the roof, you'll have a nice opportunity to make the laminotomy. Made the laminotomy, the bullet had done most of its work. The other image that you see on the far right is actually the entry point, and if you look on the far right image, you can get a sense as to how large the incision is, which is closed with Dermabond, and it's a watertight closure. Yes, CSF leak and various nerve roots were floating about. I do put a piece of Duragen down there because, I don't know, it makes me feel good. Top it off with some Duraceal, but the tissue collapses nicely right on top. Make certain you close the fascia nicely. Close at least one layer to get the skin approximation to a watertight closure. I didn't have her lay down for any particular reason. We weren't leaking CSF out of the other opening. I just sort of let that heal by secondary intention. But I just thought this was a neat case with what you can do through the tube. So again, advantages of using the tube: you can do discectomies, hemilaminectomies, whatever it is your heart desires, but you just have to know the anatomy very well because you don't see a lot. It's tactile. So here's just the serial dilation devices. I had to put where I got this from because I couldn't find any images on the line and I didn't have any. So back to what I thought was interesting in my presentation. This is last year. And I thought this was very interesting. Where's Victor? Oh, there he is. You should remember this picture. Hippos are the #9 killer of humans on the planet. On average, they kill 500 human beings a year. So I looked up what are the 10 most dangerous animals, and obviously it was the hippo. I forgot the name of the restaurant, but we decided after dinner to test our luck, and there's Victor slowly walking his way out to this lovely hippo. I always find it amazing, the wildlife here. I can't run faster than the hippo, so even though I am taking that picture, he is much closer. Next, what else can you do through a tube and through a small incision? I do a lot of revision surgery, and I'm not a big fan of posterior instrumentation anymore because, as we saw in our pain colleagues' discussion, the question as to whether or not spine stimulators can help for a lot of axial back pain is becoming more and more to the forefront. When you go in and you open somebody's back and you put instrumentation, you cauterize, you do a laminectomy, and then you put screws in there, you are changing their back forever. We can talk about all you want with sagittal balance. You can talk about all you want with how beautiful your screws are. Bottom line is everybody's anatomy is fundamentally changed. So as a result, you develop the adjacent segment degeneration. And I have a gentleman who just came in. I've got continued axial back pain after his initial surgery. He doesn't want more screws or rods because he remembered how comfortable that initial surgery was. He also had a prior posterior wound infection because, as Hiran kindly pointed out, most of my patients have a BMI over 40, which is actually very true. I've had people that are too big for my OR table because I think the Jackson table is, 21 inches wide. And some of these patients I can't even get on the table without it actually bowing down. And the ability to get an x-ray through these human beings is almost impossible. So you have to find something where you can actually revise them safely. And if you've got somebody with a prior wound infection, a BMI over 40, hypertension, cardiac issues, diabetes that's uncontrolled, and they eat McDonald's every day, McDonald's just won't heal your wound. So try the French fries, add a little extra salt, and a chocolate milkshake, maybe it'll work better. So the guy asked me just to fix it, and I said, well, okay, but understand you're still going to have some back pain, but I have a way to fix it. So I have these additional images, which you can see, obviously the CTs on the left, the MRIs on the right, and I'm focusing on the adjacent segment where you just have a little bit of loss of coronal balance, you've got subtle modic changes, you have a little bit of canal stenosis, but again, it's axial back pain. So how would people fix it here in the room? Remember, I'm going to use a tube. XLIF.
Was it fused before Was it fused before one?
Yes. Well, it's fused. The definition of fusion is quite variable because you'll see, hey, I was fused, and then you get a CT scan, you don't even see a fusion mass. So what is a fusion? But I don't want to embark on that. But it's instrumented from 4 to 1, and they've developed the axial back pain. So I have this interesting photograph, and some of you may or may not appreciate the style that it is made. But if you walk through all these pictures, do we have a laser pointer, or should I just point? Okay. The XLIF is a very, very powerful surgery. And you start walking through with putting the retractor in. You can see the level of surgery I'm interested in, which is right here. Just like Victor says, I do a left-sided approach, and my intent was to do a 2-level XLIF because the 2 adjacent segments were an issue. I didn't want to put posterior instrumentation in because we're starting to approach the thoracolumbar junction, and I also didn't want to risk another wound infection. Plus, I didn't feel like taking the screws and rods out. So if we walk along this, you can sort of get a sense as to how I'm putting the separate implants in. These are a little small for me. I usually put in 26 millimeter implants, but I chose to put in 22 millimeters. They're 50 millimeters in length. I sometimes will use titanium-based implants, but I've actually switched back over to PEEK. And I typically use PEEK with osteocell. I get in my opinion, the best fusion with that. But what I'm trying to do, once again, is restore disc height, maintain at least a degree of lumbar lordosis. I think I've got a standing Scoli films. Here's the finished product. I do like to put my implants a little bit more posterior. Sometimes with the larger implants, you get a little too anterior. You take out the anterior longitudinal ligament. You end up destabilizing them inadvertently, and sometimes you're then forced to increase or lengthen your posterior fixation. But the reason why I'm showing this is, once again, it's minimally invasive. You can do this through single incision. These are my intraoperative pictures. This is not the same retractor that Dr. O'War uses because I have some company that's trying to entice me to use their stuff. Their stuff is great in their own mind, not in mine, but I use it anyways because I like the entertainment value. But once again, you can see the retractor, left side up. You have an incision that's approximately, 1.5 to 2 inches in size. You're able to flare your retractor, and you're able to move it in such a way that you can keep the retractor in one location and actually get from one disc space to the other. Typically, you want to use some angled instruments. This is a shot that sort of goes straight down. Unfortunately, the resolution isn't good enough, but if you look there, I am working, and I've already completed the surgery, the implant's there. I do a shallow docking technique because people talk about, if you move the psoas too much, you're going to hit the lumbar plexus, or you'll cause all these other issues. I dock on top of the psoas, I bamboo it open. You can dissect the psoas away from the underlying vertebral body, and if you just use two separate motions where you come in parallel to the muscle fibers in the psoas, turn your hand perpendicular, you get a nice exposure, and you just keep working in and out without stretching the psoas muscle. So it's a modification of the shallow docking technique. People that do a lot of X lifts talk about putting a brooch, not the brooch, but the shim in. I never use a shim. But still, adjacent segment degeneration accomplished through a small incision. You usually lose about 20 cc's. They're up and walking. Minimal wound infection. And here's the before and after. You can get a sense this is actually a scoliosis series. And that's a standing x-ray. This is also an example of another X-lift, which I always find interesting. This lady came in with pretty much isolated disease. I decided to do the single level X-lift. The interval is 15 months. You can see on the left and the right the difference between the degenerative process. And these are standalone implants without a lateral plate. The area that's up above the adjacent level kind of looks worse, but she has been asymptomatic since I put the lateral implant in. Just a reminder, how many hippos do people kill annually? 500. Victor, don't chase them, especially if we're going to go there tonight or tomorrow. So here is a case where we were talking about burst fractures and minimally invasive approaches to burst fractures. So I had a 32-year-old male who was involved in a motor vehicle accident. He presented with monoparesis of the right lower extremity. I was not there at the time. I'm a solitary neurosurgeon, but I had a locums covering who decided with this, which was actually a 3-column injury, to do a posterior laminectomy and leave him alone. So I came back in, the guy had a laminectomy performed, and he's laying in bed with monoparesis and an unstable spine. So I thought to myself, wow, that's a really nice gift. Happy New Year to me. And what do we do with that? So of course we can talk about the thoracolumbar, injury classification. In my mind, this is somebody that needed an anterior-posterior fixation. So where do we go from there? He'd already had a posterior laminectomy. You can see on these films that he's missing spinous process. He had a 3-level laminectomy to quote-unquote decompress the neuroelements. We can debate if that's the right thing, but in this particular case, I felt that a lot more was required. He'd also had a L5S1 instrumented fusion when he was a kid for a spondylolisthesis. So the first step, like Victor had brought up, is you kind of want to secure this fracture because we're going to start moving them around. So I just opened up. I didn't want to do percutaneous screws. I already had an incision there. So I decided to come one up, one down, and just stabilize it so I could put them into a lateral position. Here is the retractor. We saw an actual picture of the same retractor. This is the invasive retractor. You're able to get around and through the psoas muscle with little difficulty. We use neuromonitoring. The guy's right leg was already taken out, so I came in through the right side. I mean, what more am I going to lose? He had no signals to begin, he had no signals to end, but if you look, you can see where we've got disc height restoration. We have a tremendous implant that goes, pole to pole with the end plates, and I was able to expand it adequately to preserve his native anatomy. Flipped him back over, tightened the screws from behind, and was able to correct it. So the lateral corpectomy, you can perform this at multiple levels. You can come in thoracically, as we've heard before, if the rib's in your way, just take it. Really doesn't matter. Use it and put it into the disc space or wherever you're planning on putting things. This x-ray, the superior end plate the cage is probably a little posteriorly, so I could probably have done it a little bit better. But I'm able to recover the disc height. We're able to come in through a small incision. I do not have navigation, so I could make a lot of comments about it, but it does help, especially when you've got the drill plugged into navigation. I do have a 3D device that I can use post-operatively. And because I was feeling generous and had taken a large piece of rib out and we had enough osteocell, if you look at the X in the right-hand image, I actually replated his ribs. So I put his ribs back and he was quite pleased with that. But again, this is another type of minimally invasive surgery. It does require a relatively high learning curve. I do my own exposures, and a retroperitoneal approach is pretty simple. You just make your lateral incision, drop your finger down to the retroperitoneal space, dissect everything out of your way. It's very tactile based. Put the dilators in and you're there. So there are two problems with these two pictures. And again, we've been coming here for a few years, and I have to thank Victor and all the guys here. I really enjoy coming. It's a lot of fun. One, across the street, my first experience with tilapia. This is the actual meal I had. They tore my damn bar down. I'm really pissed about it. They opened something new across the street, but the place across the street was actually really awesome. And then, remember the boat ride here? We get there, where's Dr. Awar?
Oh, yeah.
So that's also the place where where Dr. Patel had the very special tour guide. And we ended up going to this animal preserve, and the tour guide had quite an affinity for Dr. Patel. Nobody got thrown into the lion cage. I'm sure I would have been the first one put there. But we were supposed to meet Dr. Awar at the restaurant, and then at the last second they changed and went somewhere else. And we sat there at this restaurant because the service was so slow. I think it was like 3 hours before we even got our first entree. But I guess that's Kenya style. Here, why do I love this trip? One, because you can never have too many strawberry milkshakes. As some people may recall, we had one of Dr. Karras' sons. I always keep forgetting his name. Owen. And it was and he mixed his strawberry milkshake with Fanta orange and every other wonderful piece of food that you can imagine. And there was a explosion of sorts all over the table. But at the same time, I always enjoy ordering birthday cakes. So if we're lucky, maybe somebody's birthday, which isn't occurring, will be ordered. And then I took this picture last year because the transportation modalities always amaze me. So this young girl was on the front of the moped, and there were two other people behind the driver. And I just thought it was just a really cool picture. I think we're going back to see the band later tonight, or is that tomorrow? Today. So I forgot who that singer was, but that was our last trip. And then here, that's Cassie, right? Who was in the front of that little bike that she had to drive around once we arrived. So there's some great memories, some great experiences. We have some really good people here. Sorry if my talk isn't the greatest, but it gives me an opportunity to say thanks to all the guys here, and thanks to everybody who attends. It's something I enjoy doing, and I hope to keep doing it for a long time. And that's last year's picture. I did lose some weight. I'm trying to bulk up and look like Dr. Awar, because I didn't look as cool as him on our TV show recently, which I'm the most hated guest in the history of it. So it's all good. Just go online and check it out. You guys won't like me anymore, but that's okay. And this is just a really cool picture of seeing the sunset on Lake Victoria. So thanks again. If you have questions about minimally invasive stuff, I'm always happy to do it, but it does require a lot of resources, requires a lot of fluoro, requires just a comfort level, but the patients recover so much faster. They require less post-operative care, and you'd be amazed at how much you can actually do through a tube. And it's just something, once you embark on it, doing open surgery just seems foreign to me at times. So questions, concerns, thoughts?